What's going on, everybody? Welcome to episode 103 of the Core Consult RX podcast. I'm Mike Corvino, Cole Swanson with me as always. What's up, man? How's it going?
Doing good. Excited for things to open up a little bit.
Heck, yes.
They started doing outdoor seating at the restaurants beside my pharmacy.
Did they?
Packed out.
Yeah.
All day.
We actually went and ate dinner at one of the Mexican restaurants, and we got to sit outside. It was the first time I'd been to a restaurant in over a month. It was weird.
Yeah.
Very weird. It also took about an hour and a half to get our food, but that's okay.
That's what it looked like.
Happy to be outside.
Sunday morning, there's like a brunch place. I mean, the line was just down the parking lot.
It's craziness. I'm also so ready for a haircut. You can't even imagine.
Dude, my wife has cut my hair twice.
Has she?
Yeah. What do you think this would look? I mean, I'd have like a mullet.
I was wondering how it stayed so pristine.
So I'm thinking if I can keep this going, I could save some serious cash. I'm thinking the cosmetology industry is going to take a hit after this.
Because so many guys are realizing how easy it is to cut dudes' hair.
Well, I won't say it's easy. It's a stressful experience, and I'm high maintenance. But
I can see it.
But she's doing a good job, I think.
That's awesome.
You know, have her cut it, once a month, and then maybe twice a year I go in and have somebody, clean it up or whatever. Yeah, save some money.
Yeah, you couldn't pay me to let Jen try. Because I don't trust her.
Well, I mean, worst case, you just shave it,
Ooh, and then I'll have to hear about it. You're bald. You look better with hair. That's what she'd be saying.
Is that how she sounds?
Yeah, I got about 3 hours left, or 3 years left before I'm just straight bald anyway, and then she has to find somebody with hair again. But yeah, so topic today.
Yes. What are we talking about?
Going to be talking about tardive dyskinesia. So
Yep.
We did an Instagram poll, and several people wanted to hear a topic on this. And so, yeah, we're going to probably end up turning this into a couple episodes at least, because oftentimes you hear tardive dyskinesia, but that gets lumped into extrapyramidal symptoms. And so we're going to probably break apart EPS and kind of go through the different types of EPS and things like that. But today we're really just going to focus on tardive dyskinesia by itself.
Because while there's other EPS symptoms, tardive is kind of its own thing. It falls under that umbrella, but definitely more serious. And we'll talk about how serious, but historically irreversible. That being said, we've had some new drugs come out the last couple of years, which are pretty exciting. Things that we have not had in the past, which means it might not be so irreversible, at least as much as it used to be.
Yeah. So just to kind of clarify, if you hear the term EPS, you're going to hear things that can kind of be lumped under that umbrella, like akathisia, Parkinsonism, dystonias, and other terminology and things like that. But tardive dyskinesia, like Cole said, is kind of its own separate thing. So we're going to kind of talk about that, even though there is a lot of overlapping between EPS and TD. And a lot of times if somebody experiences EPS symptoms like kind of early on in their antipsychotic therapy or whatever the case may be, that puts them at higher risk most likely for tardive dyskinesia later on. We're going to focus just on tardive dyskinesia and kind of go through the different drug options and things like that. And then we'll go back over EPS by itself.
Yeah.
So don't want to kind of confuse everybody with all this.
Yeah.
So my initial plan was to just try to do all movement disorders, and Cole was like, "That's dumb."
Well, it didn't seem too bad, and then we're like, oh, we can actually, there's a lot to get into.
And the thing is at this point, we're really stretching for topics that we feel even remotely comfortable covering. So we got to make these things last.
Well, what it means is we just have to learn some things.
Yeah. The whole point of this podcast is just to see how far we can stretch our knowledge and then just slowly just scale out of business that way.
Right.
So it's going to be good.
Yeah, it's going to be good.
So tardive dyskinesia, by definition, that is like a fast movement or hyperkinetic, if you will, disorder associated with a prolonged use of dopamine receptor blocking agents. So when we think of that, we think of typically like our first generation antipsychotics, some possibly our second generation as well. Other drugs can also cause that, but we'll kind of go into those. But that's kind of like the broad definition of tardive dyskinesia itself. We'll talk about some other tardive disorders, tardive syndromes, just to kind of mention those. But tardive dyskinesia is the one you'll most likely discuss in, general pharmacotherapy and things like that.
Right. And like Mike said, usually is associated with antipsychotic therapy. It has to do with dopamine receptors, and we'll talk about, like Mike said, how it can occur. As far as what it looks like, typical clinical manifestations can be brief, regular contractions that aren't repetitive or rhythmic, but they kind of appear to flow from one muscle to the next. Can also be sinuous, slow writhing movements, are very typical of tardive, and this can be called athetosis. Dystonia would be more of a sustained muscle contraction, right? So an increase in tone or an odd tone. It can cause twisting, repetitive movement, even abnormal postures. Other forms of tardive that are stereotypical would be like the lip pursing. You may have even had patients with this or known people with this. Or they might express their tongue, and it's uncontrollable and frequently irreversible. Lip smacking, even chewing movements, all those are characteristic of tardive.
And that's usually the way it's kind of broken up to is the oral, buccolingual, kind of facial dyskinesias. And then there's also like the limb and trunk and respiratory involvement as well. But like Cole was saying, all the different ways it can kind of be expressed in the face, there's so many different ones. If you go on UpToDate, for those of you who have access to UpToDate, one thing that's unique about if you're looking at the Tardive Dyskinesia article that's on there, they actually have clips that show patient examples of them experiencing that. So they have like an oral buccolingual patient it's showing like the puckering, the smacking of the lips, the bulging cheeks. It's a really pronounced case of TD. And so it's a way of kind of seeing what that actually looks like. 'Cause it's hard to read about that until you actually see it.
Right.
And then it's same with like the movements that involve like the limb or the trunk. They have like twisting, spreading of the fingers. They call it piano playing finger movements, tapping the foot, things like that. Shoulder shrugging, rocking and swaying movements, hip thrusting, rotating the hips, and they all have clips that you can watch on UpToDate. So if you do have access to, if you don't have access to UpToDate, sorry, I don't mean to. Maybe we can get
Do you have $600?
Yeah, but if hopefully for those of you who do have UpToDate, make sure you check those out because it is interesting and definitely something to kind of take a look at. As far as like what causes the tardive dyskinesia, obviously we know kind of usually the culprit is a medication, but there's multiple kind of hypotheses as far as the true mechanism, and so. One mechanism is that there's this upregulation of striatal dopamine receptors, and that happens after that chronic exposure to a patient having low dopamine states, and that kind of creates this like super sensitive or super sensitivity to the side effects of the drug. There's also a hypothesis that talks about, like actual structural changes to neurons, or even like the dopamine receptors themselves. We have dopamine 1 and dopamine 2 subtype receptors, and there's one theory that revolves around like the imbalance of those. There's also a hypothesis that talks about GABA, and then like where you get this GABA blockade of the D2 receptors, and that's going to increase the release of glutamate, which if you remember is like an excitatory neurotransmitter, and that cytotoxic effects kind of can destroy the striatal and GABA inhibitory neurons, and so you kind of have the patient more susceptible to these side effects to begin with. So there's not really like a true definitive like known mechanism. There's multiple hypotheses, but we still at this point don't fully know what's going on. It maybe just a combination of several things, but those are the main four kind of recognized hypothetical mechanisms.
Right, but I mean they see that clearly it's associated with these dopamine blocking drugs. So
right.
Pretty solid hypotheses, I would think.
Yeah.
They're at least associated with the drugs, and now we have some options that could combat it. I do want to say at the outset that if you're starting any patient on an antipsychotic, it's important to make them aware that this is a possibility. If patients have a history of antipsychotic use, they may already know or have friends who have had this because they can be very self-conscious about it. Because if you've seen it, then you might associate it with somebody that you might associate a psych disorder with, and people know that. So there's not too many drugs where there is a actual physical manifestation that tells everybody that you're taking that drug. But Tardive can be one, and it's kind of a physical manifestation that tells people that you are currently or have taken antipsychotics. And so people might naturally associate it with that. So make sure patients are aware that this is a possibility before they start, and frequently monitor. Anytime you see them, be on the lookout or ask them about these symptoms, because getting on top of it early can help. And, once it's permanent, and at that point you're having to treat.
So, like I mentioned too, the tardive dyskinesia is one type of tardive syndrome, which is kind of the overarching term. So there's other ways that this can kind of manifest. And the way they break it up is, so we have like tardive chorea, which is going to be like rapid contraction of the limb, face, or trunk. Tardive dyskinesia is more of the fast, repetitive, rhythmic movements. Tardive dystonia is where you get this, like Cole said, the sustained muscle contraction. And they also have things like tardive myoclonus, which is this like very rapid, almost like a shock-like jerk that patients can get. And then they have tardive tics, which is like a cranial musculature kind of stereotypical movement that we think of when we think of like a true like tic, and it can even be verbalized in some kinds of, so patients will actually have like a grunt or just little small vocalizations of that. The thing with, because it's a tic, it can actually be like voluntarily suppressed if the patient is trying hard to suppress it or if they're distracted by something else, but they are definitely bothersome and decrease quality of life and things as well. So those are all terms that you may see, and it's kind of the way they break it up, under that tardive syndrome category.
Right. So how common is it? You might think, well, I've never really seen a patient with this, even though maybe I've seen people with it in real life. Not too concerned about it. So there was a meta-analysis that was done, included about 56 studies, 35,000 patients treated with antipsychotic drugs. They found that about 20%, 1 in 5, had some sort of tardive dyskinesia. Going a little deeper, they saw that around 11,000 of those patients had some sort of spontaneous dyskinesia that wasn't necessarily associated with antipsychotic exposure because they weren't on an antipsychotic. So taking that into account, you can expect about 15% of patients treated with an antipsychotic could have tardive dyskinesia. At the very least, it's going to significantly increase your risk for it. So there's a good chance that you're going to see somebody with it if your patient population includes anyone who could be taking these drugs. And
so as far as like its actual, the way that it kind of actually presents its clinical course is it happens slowly. So it's got kind of this insidious nature, and it usually can happen over the course of as short as days up to weeks while the patient's starting the drug and kind of tapering up. But it also can actually emerge after the patient has a reduction in the dose, which seems a little weird, or if the patient has an abrupt discontinuation, that can actually kind of throw it off as well. And that can happen, later on as well. So there's patients that will be fine in the beginning, and then all of a sudden a year or more after that, sort of having these symptoms start to emerge. Or like I said, again, if you stop it abruptly, they can have the symptoms emerge at that point.
Right. So it's not guaranteed that if you have tardive from one of these drugs that it's going to be permanent. So there is a spontaneous remission of tardive that's possible. So discontinuing the affecting drug is probably what you're going to want to do. And there is maybe 50-50 chance that it just spontaneously remits. It's more likely to remit in younger patients than older patients, so the incidence in older patients is more. Sometimes it can take a long time. It can take months to years for it to remit. But still, a significant portion of those patients who have tardive are going to have it for the long term.
And that's something I was, because when I'm in school and things like that, I remember thinking like, well, it's just a matter of getting the drug out of the system
Yeah.
And then there you get, but no, you
Which
could
we'll talk about that with other EPS issues. That is a reasonable thing to do, but with tardive, it's different.
Yeah, I mean, that. In fact, I saw this in a 20-year-old patient who had been taking, I forget which, it was a first generation antipsychotic, and they had been on it for a very long time. It turned into this whole thing where maybe the patient didn't even need it, but they were, keeping him on it for other reasons. Things. It was a whole mess. And the patient he was 20 years old and he had, severe, very obvious symptoms. And he had been off the medication completely for a year. And I remember he's going, why is this not gone yet? And we had to explain to him, it may not.
Yeah. And even if it does, it could still take 3 years before it goes away.
That's really sucky conversation to have with a 20-year-old.
Yeah. And we didn't really mention this at the beginning either, but for any EPS type syndrome, the first generations are going to be higher risk because they have a higher affinity for the D2 receptor, and more dopamine blockade is going to increase your risk for these symptoms.
Yeah. So as far as risk factors, seems to be that women in general are at higher risk than men, as well as ethnicity. African Americans seem to be at higher risk than other races. Old age definitely is a risk factor. So there's some studies that have estimated you have a 6 times greater chance in patients who are 65 and over compared to younger patients. And so being extra cautious, which in most cases, especially with all the different adverse effects that can happen with antipsychotics and things like that, we're going to use a lot more caution in elderly patients anyway. But we definitely have to be aware that the chance of them developing TD is higher. Also, patients that have had some sort of, exposure to, whether the exposure itself has been, for a very long duration. So they've been on the drugs for a long time. The longer they've been on it, the higher the kind of risk goes up. They have uncontrolled diabetes, which is another one. So, obviously in South Carolina where we live, we have an incredibly high rate of uncontrolled diabetes around here because we have terrible diets in South Carolina. And so it's something that I personally, until we were kind of looking at stuff for this this podcast episode, diabetes actually wasn't one I was really even considering.
No,
because and
it's one of the less established ones, but still, it is. It can increase your risk.
And patients that have had some sort of a traumatic brain injury as well seems to put them at risk. And we'll talk about some other drugs that can cause it as well. Metoclopramide. It's always a culprit you have to be aware of, so we'll mention that. But so we'll talk about that in a second. But those are the kind of the established risk factors.
Right.
So again, antipsychotic use, most common cause. And then as far as tardive syndromes, tardive dyskinesia is going to be the most typically seen version of that.
Yep. Okay.
All right.
Want to talk about some clinical stuff, some treatment? What we got?
I guess.
Only the most important part of this, right?
Only part we somewhat should be even talking about.
Right.
Yeah, go ahead.
Yeah, but so before that, we mentioned that younger patients can remit. Remission rate for elderly patients is low. But interestingly, symptoms may not worsen. So if you have tardive and then you continue on the drug, which we generally do not want to do, the symptoms may not worsen from that point, but they very well may become permanent. Frequently, there can be distress and disability caused by symptoms, and so that's why we want to treat. So I talked about the patients feeling self-conscious. Also, I've had patients who have it who it literally impairs their speech because they're having so many facial tics or tics with the mouth that they have trouble talking. And sometimes it's worse. So they'll even comment, they'll say, oh, my tardive's acting up again. So they're literally having trouble communicating with me. So improving that and improving quality of life can be very beneficial to patients.
All right. So as far as the actual treatment of tardive dyskinesia, one of the first kind of things to go with, and I shouldn't even say tardive dyskinesia, but tardive syndromes in general, would be, as we are using these medications, specifically, antipsychotics, we want to use the lowest effective dose possible. And so that's kind of the first step, and then titrate them up as well. So you don't want to just start with a high dose antipsychotic, which if you're doing, any psychiatrist is going to obviously know that. But if there are cases where, maybe you're in a rural area where the patient doesn't have access to that and it's a family medicine doc or something that's working with patients, making sure that they're not jumping to higher doses and starting, it's kind of like the whole beta blocker idea of start low and go slow type of thing. When you're coming, if you do develop like those symptoms, then the big question is, depending on what's causing it. So if, let's say they're on a typical antipsychotic, so first generation, one thing we could do is potentially switch to an atypical. Now, as far as like the true data showing that that's effective, it's kind of hit or miss as far as the different studies that are out there, but it's definitely something that's a reasonable choice to try, and switching them to a second generation, which is going to have a lot less specificity for a specific dopamine receptor, and that's going to hopefully take away some of that risk. There's even like this cross taper strategy that you'll see with quetiapine or clozapine, which seem to be the two second generations that have the least likely occurrence of any kind of EPS or tardive syndromes. And so there's switching to those or cross tapering with those two agents is one potential option.
Yep.
The other thing is to and this is actually from UpToDate has like a whole section on this where they talk about metoclopramide, and they have, and they mention specifically, if you have a patient, because you'll see patients that have like gastroparesis or something like that going on where they're on metoclopramide, you even see it as an antiemetic. Please don't do that.
Yeah.
EPS and tardive dyskinesia specifically is very high risk with metoclopramide. So, understandably, if the patient has gastroparesis or something like that, maybe they need, that metoclopramide agent on board for a period of time, but they really recommend not using it at least continuously for longer than 12 weeks because the risk will go up from there. So if you have a patient that's been on metoclopramide for a long time, definitely looking at potentially stopping that would be, or never starting in the first place is even better. But metoclopramide is an agent you should, especially as pharmacists, you should be kind of looking at as a risk factor. And
we haven't done gastroparesis, have we?
I don't think so.
Nice. Another topic, write it down. I remember when I was, because I don't do inpatient right now, but I remember like when I was in school on rotation, there was one hospital I was at that literally had, there was one floor that had like a standing order for metoclopramide as their, antiemetic. And I remember the pharmacist I was with like daily was like, can we please stop metoclopramide? And he was on it. And so it's something to kind of watch out for. There's a group, the American Psychiatric Association Task Force, kind of has recommendations out there about tardive dyskinesia. And one of the big things they talk about is long-term use of antipsychotic drugs in patients with like depression or anxiety, even like chronic pain states and things like that, they say is discouraged. So there's a lot of data now coming out that shows some of these, like, you'll see data with like aripiprazole and some of these drugs that are working in general depression disorder, especially ones that have other kind of subcategories of that, whether it's like depression with anxiety or mixed symptom depression, things like that, where you start seeing these antipsychotics kind of coming up. And it's not that they're saying that you can't use that, but they want you to at least reevaluate them before you just put them on that long term and keep them on that. So that's something to kind of consider. And they also talk about, they actually dropped the age down to 50 as far as really like watching these patients closely, even the ones that have schizophrenia, and depending on whether or not they need to truly be on that. They mentioned metoclopramide, and then they really encourage the use of the abnormal involuntary movement scale, which is the AIMS form. You'll see that, and you can download up the internet and take a look at it. UpToDate has a version of it, and that's going to kind of like they want you to use that to kind of increase awareness of mild manifestations of tardive dyskinesia. So they have a whole section, and again, go on UpToDate if you have access to that, and there's a whole huge section on that task force. Yeah. Okay. So what options do we have? So what are the new kids on the block? So The class is second generation VMAT2 inhibitors. So I'll talk a little bit about what those are. The names of the drugs are deutetrabenazine and valbenazine. So valbenazine is Ingrezza, and deutetrabenazine is Austedo. So you may have heard of those already, but they are the new kids on the block and some novel treatments for tardive dyskinesia, because we didn't really have anything before. I did want to say that when a patient obviously has a psych disorder, they very well may need to stay on psychotic meds. So we talked about discontinuing the affecting agent for tardive, but that's not always possible, or it's not always totally possible to get them off all dopamine blocking agents. So if that's the case, you're going to need to have a risk-benefit conversation with the patient, and also consider the use of drugs to mitigate the tardive and allow them to have better quality of life on their dopamine blocking treatment. So let's talk a little bit about the mechanism of action. So the VMAT is a vesicular monoamine transporter 2. So we're inhibiting that, and we're reducing the available dopamine via either alpha or beta metabolites. They block sequestration in the presynaptic vesicles and are ultimately just aiding dopamine signaling. So they're reducing dopamine levels in the presynaptic neuron, so there's less dopamine signaling to the postsynaptic neuron. And this helps reduce the involuntary muscle movements. Some side effects of them are fatigue or somnolence, diarrhea, dry mouth. They both, you obviously, for the reasons of the mechanism of action, want to avoid MAOIs being taken with them. They do have a black box warning for suicide risk or suicidal ideation in patients with Huntington's disease. I believe the reasoning for that is because there's also a first generation VMAT2 inhibitor called tetrabenazine. And the brand name, it's kind of funny, but it's Xenazine. And that's specifically used for involuntary muscle movements in Huntington's disease. So it's sometimes listed as an option for TD. I don't think you're going to want to use that, especially for sure over the other two agents. Doesn't really have great evidence for it. But I think that the use of that in Huntington's has created this black box warning for suicidal risk in Huntington's for the second generation ones. The deutetrabenazine, which is the Austedo, you usually start it as far as dosing goes at 6 milligrams per day. You can increase every week by 6 milligrams, and the max dose is about 48 milligrams a day. But yeah, those are the options, and they can be helpful. I've actually seen a patient try both. I think they started out on Ingrezza and didn't get the results that they wanted, and they ended up on Austedo, but I think they're actually doing well on Austedo now. So it's interesting.
And I'm looking to double check myself, but I think the Austedo is the one that has the black box warning specifically for that suicide risk of Huntington's disease. It's not
Ingrezza, it's just Austedo.
Right.
You're right.
Okay. And then the other thing with valbenazine is the QT. I was thinking about the Huntington's, so you may have mentioned this, but QT prolongation is specifically something to watch out for with the valbenazine.
Yep.
And so as far as like evidence goes, the valbenazine has better data. So does the Austedo, the deutetrabenazine. I can never pronounce that word. They definitely have better evidence than, like Cole was saying, the tetrabenazine, the older agent. If you look at like psychopharmacology institutes, they, when they summarize their data, they talk about that only being level C evidence, and so they have it listed as only possibly effective and a lot more severe side effects. So really, that first generation VMAT2 inhibitor should be kind of like thrown off if at all possible, and sticking with one of the two second generations. As far as Ingrezza, in order to actually dispense that, you have to be a specialty pharmacy or get registered. Because I know that's one we ran into that problem with trying to get that for a patient. We ended up having to call the company, try to get registered. It was a whole long process. Yeah. Austedo was actually a lot easier to get our patients on, at least for us. But we're not a specialty pharmacy. So for the pharmacists out there, if you're dispensing, definitely you can get access to it, but it's not the easiest thing. And if you're one of like the big chain pharmacists, then I'm sure you have your specialty mail order facilities that you can go through, and I'm sure they can get access to it. But just for your standard dispensing pharmacy, it's not going to be the easiest. So just to kind of be aware of that.
Yeah.
All right. So the next thing that I think a lot of people kind of jump to is anticholinergics. Like you'll see cogentin, so benztropine, and things like that. Now, the big like kind of I guess switch in the way this is treated is anticholinergics are actually, with the most recent data, shown to really not be all that effective for TD, and so anticholinergics, they have a lot of significant side effects. And there's a study that came out last summer, so it was June or July of 2019, I believe, in JAMA, that showed the increased risk of dementia in patients, elderly patients using anticholinergics. So because these patients are the highest risk for developing tardive syndromes, then sure, we give them anticholinergics, we may not even get that much benefit from it. And then on top of that, we put them at potentially, at least statistically, increased risk of having dementia as well. So not a great option. And in fact, the algorithm that like Psychopharmacology Institute put out, they don't even have anticholinergics included. They literally want you to use all the other options before using that. So it's kind of interesting because I know, before I started looking back through some of the most recent data, anticholinergics at least were in the back of my mind as far as prophylactic use and things like that. But it's really kind of trying to get away from that now.
Right. But still used in other EPS.
Yes.
Yeah, but not Tardive. Other options include Klonopin, ginkgo biloba, and amantadine. So Klonopin, it seems to work okay, probably a better option than anticholinergics. Still, we have our concerns with benzos, right? Especially in the elderly. It's nice, right? So, good to be cautious. Ginkgo, interestingly, does have pretty solid evidence as far as like, herbal type remedies go, which is kind of cool. Much better tolerated than I would say Klonopin or anticholinergics as far as less side effects go. And it may help. So, to me, that's worth a try for sure.
The one thing I will say to consider is because again, a lot of these patients are going to be elderly, would be as far as drug interactions. I always think any of the herbal supplements that start with a G, which that does not always apply because there's a bunch of them, but the major ones like ginkgo, ginseng, garlic, do have a potential for like decreasing like platelet aggregation. And so patients that are on like antiplatelets or anticoagulation medications, things like that, you could potentially increase the risk of bleed. Now, how clinically significant that is, hit or miss, but you might run into that patient that's on dual antiplatelet therapy,
right?
Post stent or something like that, and this would be an option at least to consider. So that's probably the cheapest option we're going to talk about is a ginkgo over the counter for this, but definitely being aware that there are drug interactions with it. Yeah, and then amantadine, I think the most the most impressive studies with amantadine. It's still not great evidence, but it's the extended release version of amantadine. And
it's like a pro-dopamine type deal. They use it in Parkinson's disease.
Yeah.
Another thing that one patient I've had has tried is Botox. Specifically may be useful for focal dystonia. Doesn't have great evidence, though. They are looking at Botox for various things. Works pretty well in migraines, I think.
Did your wife use that at all?
Well, she doesn't do migraines anymore. She just does memory, but they did use it when she was doing migraines.
Gotcha.
For sure.
Cool.
Yeah. Also, deep brain stimulation. Still not great evidence. Would only probably consider it as a last resort in like severe TD. But, other things they're looking into.
Yeah. Apparently, there's the best evidence is showing like when you have a patient that has really severe TD, then placing the leads on the globus pallidus interna, I believe is how you pronounce it, is
it's how the cool kids say it.
It's how the cool kids say it, yeah. Anytime I start talking about neurology is when I really remember how dumb I am. But that shows to be where the studies are kind of looking at there, but still kind of like a level C evidence, but I'm sure more to come as they continue to research it.
Sure. So yeah, if we had to algorithmize this, so if we had to create an algorithm out of it.
Perfect.
Yep, I nailed it. We'd probably say use the lowest effective dose of the antipsychotic, the dopamine blocking agent, to reduce risk for TD. If we need to keep them on that and treat it, we're going to start with our second gen VMAT2 inhibitors that we talked about. And then alternatively, if we can't do that for price or other reasons, consider Klonopin or consider ginkgo biloba, amantadine, and those reserve therapies.
Yep.
And we're not going to consider anticholinergics because, not great in the elderly, low evidence.
Evidence is trash.
Yeah.
As I like to say.
Yep. Trash. It's your favorite way to describe anything.
It really
bad,
is. I started including that in most of my slide sets for my PA students.
Mm-hmm. Yeah.
Especially diabetes. I have a whole long table of, I have Corvino approved, semi-trash, trash, and then ultra trash.
Nice.
Yeah, it's great. One of my students made that, and it's my new favorite thing.
We have level of evidence A, B, C, D, and ultra trash.
Ultra trash.
Nice.
Yeah, I'm really hoping that the FDA starts to incorporate that. We'll see. But yeah, so that's kind of TD, I guess, in a what's the word I'm looking for?
I think it's nutshell.
Nutshell. I almost said eggshell. Way to mess up the stupid saying.
I don't even know what that saying means.
Yeah, it's dumb.
I guess an eggshell would be a longer podcast and a nutshell would be a shorter podcast.
Yeah.
Eggshells are bigger.
Sounds reasonable.
I think so.
So, anything else you got for that?
No, I just wanted to reiterate, just make sure you're monitoring it for it. Any patient that's on it, just keep an eye out, ask them some questions. If it seems like it's TD, it's probably TD.
And get look over that AIMS form too.
Yeah.
The AIMS score is something you can kind of use, at least in kind of recognizing mild symptoms and being aware that can kind of help.
Right.
So take a look at that. It's easy to find, but definitely a good option to look at. Anything else?
That's all I got, man.
Me too. All right, y'all. Well, thank you so much for taking the time to listen. We always appreciate it. Really, we've gotten a lot of emails and things lately, and that means the world to us. We really, really appreciate you guys taking the time to listen to our podcast when there's thousands of others on the iTunes and Spotify and everything. Thanks to all of our new, we have a huge influx of Irish listeners now, which is awesome. You guys have the best accents in the business for
Fantastic.
sure. I'm very jealous.
I hear the bars over there are closed for a little while, so I guess you're going to be listening to some podcasts.
There you go. Fine. It's the next best thing. Not quite. But yeah, so thank you guys so much for following and listening. We really appreciate it. I think we may be having one of our Irish colleagues on pretty soon, hopefully.
We'll see.
But anyways, if you guys have any questions or, concerns, comments, you want to ridicule us, that's cool. You can send us an email. Our emails will be below in the show notes. We also, you can find us on any of the social media platforms pretty much. You can text us directly, area code 415-943-6116. And, if you ever have suggestions or things you want to hear, that'd be great. Also, if you do want to support the podcast, make sure you check out Patreon. So it's patreon.com/coreconsultrx. And I've been posting my lectures from my PA's class up on Patreon, and I have my slide sets you can download. It costs like $3 a month is like the minimum to donate for that. Honestly, if you're a student, you don't have the money for it, just send me a message and I'll give you the link for free. I'm not really that worried about it. All the proceeds are going back into making the podcast that much better. It's not like Cole and I are going to be buying sports cars at this point anyway.
And now if you see us riding around, Charleston with a sports car, call us out. It's fine.
Or we just bought it with our regular money.
Which I would never do.
But I might.
I would never buy a new car. We'll talk about that later.
Yeah. But so check that out if you can. Like I said, if it's something that you guys feel like, if it's a student, you want to check it out, but you can't afford it, please reach out to me. I'll give it to you for free. I'm not that worried about it. Or heck, just one person spend $3 and then just share the code with all your friends and you can rip this off that way. Again,
or Netflix.
My biggest thing is that I want you guys to learn with this podcast. So I'm not gonna put any barriers to that up there. So check that out. And again, appreciate everything you guys do for us listening and taking the time. We greatly appreciate it. We'll talk to you soon. See ya.